So we are reaching the conclusion of the resident program. So this week I'll be discussing chest X-ray, and in the coming weeks, 1 week will be AVG, and along with that, ventilator graphs, and another week will be tuberculosis 2023. So I hope with this we will be completing majority of the portion. So we have already done 4 case scenarios. So I think most probably next week we will be doing tuberculosis. Later the concluding topics will be ABG and ventilator graphs. And in between, if time permits, we'll see another topic. And today my main focus will be on chest X-ray. Whereas CT scan, the important spotters I'll be uploading, and meanwhile what all topics we have discussed and also other topics, I'll also upload the complete OSCE pattern, so virtual OSCE, the list of questions. So I think more will be having some 40 to 50 that I'll upload. So this course most probably will get concluded in the second or third week of April. And the videos will be available from the day of subscription up to 6 months. So when I find time, in between I'll be adding some short videos and short topics. Okay. First let us see interpretation of a normal chest X-ray. So most of you, what you do is, if at all in the final exam, examiner is giving you a X-ray, so you'll find out a consolidation and just say it is consolidation, or you'll find out a cavity and just call it as cavity. But the problem here is, examiner wants you to tell in a systematic manner. He expects you, what is this part? So he wants you to call it as, this is a chest X-ray. He wants you to tell you what is the view. It is a chest X-ray PA view, and he wants you to tell whether it is adequately exposed, underexposed or overexposed. Then he wants you to tell you whether it was an inspiratory film or expiratory film. Okay, so part, view, exposure, whether it is an inspiratory film, expiratory film, and is there any rotation. So after that you have to describe the pathology. So just by seeing the chest X-ray, you have been given, this is a cavity, this is a pleural effusion, examiner will become very furious. So you should mention, this is a chest X-ray, PA view, adequately exposed, inspiratory film, so no rotation, showing. Then your answer should be showing right upper lobe or right upper zone cavity, left-sided pleural effusion. So now how to tell what is the view, exposure, the adequacy of inspiration, is there any rotation, that I am going to discuss. Like I told you students, part is very important. Chest X-ray you should tell, even though you know, examiner know it is a chest X-ray, you should mention it is a chest X-ray. View, so view, like I have mentioned, view, is it AP or PA view? And what is the exposure? Is it adequately exposed, underexposed or overexposed? Is there any rotation? And what is the degree of inspiration? Is it an inspiratory film or expiratory film? Then you should go to the proper scanning of the film. Now I'll quickly tell you how to identify whether it is AP view or PA view, and those students in the chat box, so you can answer. When do you call it as PA view? When do you call it as AP view? First question, when you say it is a PA view, examiner will ask you, how do you say that this is PA view? Let us understand the difference between AP and PA view. So AP means antero-posterior view. Generally, scapulas will overlie. So if you see the X-ray within the lung fields, you can see good scapulas. Ribs appear more horizontal, and there can be apparent cardiomegaly, and the posterior thoracic cage and scapula well visualized. So generally AP view is done in supine position. Antero-posterior view is done in supine position. Whereas PA view, it is generally done in standing position. Here, this is more for visualization of lung parenchyma. This is more for visualization of bones. And here scapulas will not overlie and the ribs will be more curved and normal sized heart. I'll tell you the simple logic to remember this. So whenever you are taking an AP view, the position of the patient is in supine position. Position of the patient is in supine position. So direction of X-ray beam from anterior to posterior. Because he is completely in supine position, so what will happen? His scapulas will be very close like this. So once the scapulas are very close, they will occupy a lot of space on the chest X-ray. And moreover, whenever you lie down, your diaphragm will slightly come up. So because of that, your heart in that space will appear little bit bigger. Because you are lying down, the ribs are not expanding properly. They will have more of an horizontal contour. Now, whereas PA view, so generally is taken like this, and usually the patient holds the cassette sometimes like this. So whenever he is holding like this, for example, or keeping his hands like this, so PA view, why it is taken? To make sure your lung parenchyma is very much visible. So you only tell me, when I keep like this or when I hold like this, these scapulas are going away. So these scapulas are going away. So once these scapulas are going away, now what will happen? Your lung fields will appear very good. So here lungs well seen. So that's why if you want to identify pathology in the lung, it is PA view. And here you are placing the cassette on the anterior portion and the beam is coming from posterior to anterior. So that's why it is called as posterior anterior. Whereas here cassette is kept on the posterior aspect. So X-ray film is kept on the posterior aspect, whereas beam is coming from anterior. So it is called antero-posterior. Now because patient is standing up, his diaphragm will go down. Once diaphragm is going down, your heart will occupy normal contour, and because this is well expanded lung, so your ribs can have a usual curved contour. So here basic logic is AP view is generally for bony landmarks. So if you want to see any fractures, you prefer AP view. If you want to see any parenchymal problem, you go for PA view. And there is a mnemonic part close to the X-ray plate is clearly visible. So in a PA view, X-ray plate is here. So the anterior portion lungs are clearly visible. Whereas in AP view, X-ray plate is posterior. That's why you see the scapula and bony landmarks very well. So you only tell me, this is first X-ray and this is second X-ray. What is first view? What is second view? So what is this view? Is it PA view or AP view? Is it PA view or AP view? Now you only see here, there is apparent cardiomegaly and ribs are appearing horizontal. Ribs are appearing more of horizontal. So this is AP view. So whereas heart is having a proper contour and ribs are in curved plane. Ribs are in curved plane. So what is number 2? This is PA view. So this is PA view. So this is AP view and this is PA view. Then coming to exposure. So this is sufficient for AP view or PA view. Coming to exposure. you have to notice whether there is adequate projection. So what is the definition of adequate projection? So the shadow of vertebral column, is faintly visible. Intervertebral spaces are not clearly visible. Each and every word is very important. Shadow of trachea normally visible up to level of clavicle as a translucent shadow. See here, the shadow of vertebral column is faintly visible. Intervertebral spaces are not clearly visible, and shadow of trachea is only visible up to level of clavicle. So this I will show you on X-ray so that you will understand better. So this is overexposed film. So in overexposed film, because you are sending the X-ray rays in high intensity, vertebral column along with intervertebral spaces will be clearly visible. Spine will also be clearly visible. Translucency of lung field will increase and opacity of heart will decrease. So whenever you send X-ray films in high intensity, whatever is black, it will become very, very black. Whatever is less white, less black, or whatever is white, it will become less white. Now underexposed, faint shadow of vertebral column not visible at all. If you see the X-rays, you will understand. Translucency of trachea not seen. Now in overexposure, what will happen? Air-filled areas become more black. So here underexposed, more white density seen. Now I'll give you 3 X-rays. So this is number 1, this is number 2, this is number 3. So you only tell me which is overexposed, which is underexposed, which is adequately exposed. Now as I told you, normally you should see the tracheal shadow up to the clavicles, and behind these intervertebral spaces should be faintly visible. So intervertebral spaces faintly visible, and also you should see the spinal cord. So spinal cord, you can see some amount of spinal cord, but what is happening here? Intervertebral spaces, intervertebral space not visible at all, and also trachea not visible. So as I told you, when X-ray rays are not passed properly, so whatever is normally black, it will not appear black. So this is underexposed. So this is underexposed. Whereas the second image, if you see, the translucency of trachea is visible. You can see faint intervertebral spaces, and you can also see spine a bit. So this is adequately exposed. And also lung fields are appearing normally, in normal translucency is appearing. So whereas here you can see trachea more prominent, and also when compared to this image, intervertebral discs are very well visible and lung fields are appearing very black. So this can be considered as overexposed. So generally, examiner will be particular about underexposed and adequately exposed. So if at all you say it is adequately exposed, he will next ask you, how do you say it is adequately exposed? So these are the points to call it as adequate exposure. Shadow of vertebral column faintly visible. Intervertebral spaces also faintly visible. Shadow of trachea normally visible up to level of clavicle. So just say it. Sir, I am able to see tracheal shadow up to the clavicle, and I could see intervertebral spaces faintly visible. So if he asks you, when do you call it as underexposed? When you are unable to see the shadow of trachea, when you are unable to see intervertebral spaces. When do you call it as overexposure? So when you see the shadow of trachea very well, and also the translucency of the lung fields will appear very black, and vertebral column with intervertebral spaces will be very clearly visible. So this is how you should know what is underexposed, what is adequately exposed, what is overexposed. So I hope you have understood part, chest X-ray, view, PA view or AP view, exposure. Underexposed, adequately exposed, or normal exposure, or overexposed. Now the difficult part is rotation, because each and every book has different meaning for rotation. I have taken from a standard chest X-ray book. This should be the guideline. So first of all, is it well centered or not? So how do you say whether the X-ray is well centered or not? So the guideline is thoracic spinous process. The thoracic spinous process should be equidistant from the medial end of each clavicle on a frontal image. So if you take the central spinous process, so this is the spinous process which will be visible on a conventional X-ray. It should be equal, it should be equidistant from the clavicle on both sides. If there is rotation, there can be pseudo-mediastinal mass. So you feel that there is some mediastinal widening, or you might abnormally think there is some opacity on that side. So the concept here is clavicle that is receding from the spinous process, the patient is rotated to that side. So on whichever side clavicle is receding, so that side you call it as patient is rotated to that side. So I have made a simple video for this. Now see here. So in this patient, if you notice, so this is the central spinous process. So here is the clavicle and here is the clavicle. So this clavicle is near and this is far away. So receding means going away. So you only tell me to which side the patient is rotated. So to which side patient is rotated. So here you have to say patient is rotated towards the left. Patient is rotated towards the left. So clavicle that is receding from spinous process, the patient is rotated towards that side. So you have to say this is a X-ray where the left side clavicle is far away from the central spinous process. So patient might be rotated to his left. Patient might be rotated to his left. So this is the simple logic. So the mnemonic here is clavicle that is receding from the spinous process, the patient is rotated towards that side. So don't get confused by reading all other books. So this is the simple logic ultimately. So you can notice here, because the patient's clavicle is far away here, because it is far away here, so to that side patient is rotated. So it is rotation to left. So patient is rotated to left. Then coming to adequacy of inspiratory effort. One very important thing, you have to see whether the film is inspiratory film or not. Sometimes if it is not inspiratory, you will miss some abnormalities. So when do you call it as inspiratory film? If 6 complete anterior or 10 posterior ribs are visible, then the patient has taken adequate inspiratory effort. Conversely, fewer than 6 anterior ribs. So just remember one thing, anterior ribs about 6. So in few books it is given as 5 to 6 ribs. So implies a poor inspiratory effort, and more than 6 anterior ribs. So more than 6 anterior ribs generally indicates hyperexpanded lungs. And what is the most important condition responsible for hyperexpanded lungs? Usually COPD, emphysema. And whenever you get emphysema as a long case, and if you say hyperinflated lungs, examiner will ask you, why is it hyperinflated? So when we have discussed the case of emphysema, I have told you the findings in the PAView. We have also discussed the retrosternal distance also. Just go through the case, or at least PDF of emphysema case discussion. There we have discussed all the radiological findings in detail. Now if there is poor inspiratory effort, because lung has not expanded properly, diaphragm must have come up. Because of that, the heart now will occupy a more bigger shape. There can be apparent cardiomegaly, apparent hilar abnormalities, apparent mediastinal contour, and because lung has not expanded properly, it might appear more white. So very simple, if it is a poor inspiratory fill, you cannot comment on anything. You cannot comment on the mediastinum. You cannot comment on the heart. You cannot comment on the lung. You cannot comment on the hilum. So this is what we see on a chest X-ray. What do you see on a chest X-ray? You see the heart, you see the mediastinal contour, you see the lung parenchyma, you see the hilum. So if there is no proper inspiratory effort, so there is no point in commenting on the X-ray. So sometimes in emergency department, you tend to see the X-ray, but you tell them, so this is a poor inspiratory effort is observed. Why it is called poor inspiratory effort? Because I am not able to see more than 6 or up to 6 anterior ribs, I am not able to see. So this is how we notice. See here, anterior ribs everybody should know. So this is the first anterior rib, second anterior rib, third anterior rib, fourth anterior rib, fifth anterior rib, and this is sixth anterior rib. So you have to take it in the mid-clavicular line. So in the mid-clavicular line, if there are more than 6 anterior ribs, it is considered as a well-expanded or good inspiratory effort. Now can anybody see in this image and tell me how many anterior ribs are there? So I will write here, this is good inspiratory effort. This is good inspiratory effort. Okay. And posterior ribs, you can count it like this: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So these are the posterior ribs. So how many anterior ribs are there? You remember one thing, anterior ribs 6. See here, how many anterior ribs are there in the second X-ray? So this is 1, this is 2, this is 3, and this is 4. So you are only able to see 1, 2, 3, 4. So is it good? Very good, Jay. 1, 2, 3, 4. It is not proper inspiratory effort. So here you can see, because inspiratory effort is not there, so heart is also appearing more white. So this is poor inspiratory effort. This is poor inspiratory effort. Good. Then here you tell me what is the abnormality here. So if you notice 1, 2, 3, 4, 5, 6, 7, 8, 9. So this is a nearly normal chest X-ray. Now what is the diagnosis in this chest X-ray? Hyperinflated lung fills, so flat diaphragms and tubular heart. So this is a hyperinflated lung field. Suggestive of which condition? COPD, emphysema. Hyperinflated lungs. So you can see more than 6. So here actually it's not 6. How much is the total? 3, 4, 5, 6, 7, 8, 9. Nearly 9 anterior ribs. So this is hyperinflated lung fields, classical of COPD emphysema. Then, now is it okay? Are you all confident regarding what is the part, what is the view, exposure or penetration, then rotation, then inspiratory effort. Now after telling this, then you should go for what is called as review of important anatomy. How to come through a systematic manner. In the emergency department, if somebody is having shortness of breath, I'll not first see lungs, I'll first see heart only. Because majority of the situation, there will be hypertension, cardiomegaly, and he'll be having crepitations and auscultation. They'll be referring to a respiratory medicine specialist, saying that he's having shortness of breath. See the heart. So see for the cardiomegaly. So a review of important anatomy, heart and the mediastinum. So what is the standard way of assessment of heart shadow? The cardiothoracic ratio should be less than 0.5. So what you have to do is, at the level of the CP angles, you draw a line. So this is called as transthoracic diameter, and at the level of heart. So usually here it is not correctly shown. You have to take the most convex part here and also most convex part here. So you have to total this. So this is called as transcardiac diameter. So normally heart should occupy less than half of the transthoracic diameter. If it is more than 0.5, a cardiothoracic ratio more than 0.5 suggests cardiomegaly. So what you need to do is, you have to see the ratio in between transcardiac diameter and transthoracic diameter. So usually it has to be less than 0.5. If it is more than 0.5, it generally indicates cardiomegaly. So if you have cardiomegaly, shortness of breath and CP angle blunting, it most probably it is nothing but cardiac failure. So it can be cardiac failure. Okay. Next, coming to cardiomegaly on the AP. Now few examiners will ask you, can you comment on the heart size on AP view? So generally there will be apparent cardiomegaly, but there is a rough way of knowing cardiomegaly even on AP view. If left heart border is touching the left lateral chest wall, then heart is enlarged. If left border is close to the left chest wall, then heart is probably enlarged. If heart is borderline enlarged on a portable AP radiograph, it is normal in size. So transthoracic diameter over the right dome of diaphragm, no, you can take from CP angle to CP angle. So you can take from CP angle to CP angle. So even if you draw on the diaphragm also, it will be nearly the same. Even if you draw on the diaphragm also, it will be nearly the same. So generally diaphragm, the sizes, the position will vary. So you can see that left diaphragm will be slightly lower than right, that I will show you later. So you can take it from CP angle to CP angle. Okay. Then see here, on an AP view, if the left heart border is touching, the lateral chest wall, left lateral chest wall, heart is definitely enlarged. If it is very close, it is probably enlarged. Then you can notice here, so both are AP views. So this is AP view and this is AP view. So here it is very close to the chest wall. In the second film, it is very close to the chest wall. So you can suspect this patient is having some cardiomegaly. This patient is having some cardiomegaly. Okay, this patient is having some cardiomegaly. So here it is not that close to chest wall. So this can be normal. Normal in AP view. Normal in AP view. So this is what I was telling you previously. Even on an AP view, you can roughly estimate whether there is cardiomegaly or not. So if the heart is definitely touching the left lateral chest wall, it is 100% cardiomegaly. If it is nearer, there is possible cardiomegaly. Then coming to assessment of cardiomediastinal contour. So on the right side, you will have a superior vena cava, right atrium. Anterior aspect, so this part is right ventricle, and there will be cardiac apex. Whereas on the left side, you will have left ventricle, left atrial appendage, pulmonary trunk, and aortic arch. So very, very important. Right side of heart in chest X-ray generally not contributed by right ventricle. So this is very important. So if you see the right border, or else we'll write right border of heart, right border of heart in chest X-ray not contributed by right ventricle. So what makes the right border? It is predominantly right atrium and part of SVC. So what makes the left heart border? The left ventricle, the left atrial appendage, the pulmonary trunk, and aortic arch. So this is very important. Few examiners will ask you, right heart border is made up of. You should tell it is right atrium, superior vena cava. Right ventricle is not a part of right heart border. Whereas left ventricle is the prominent part of left heart border. So this is very important. Left ventricle is a prominent part of left heart border. Whereas in the right heart border, it is generally not made up of right ventricle. Then assessment of hilar regions. So next thing, after seeing the mediastinal contour and right heart border, left heart border, you look at the hilar. Generally, hilar should be of similar density. The left hilum is generally slightly higher by 1 centimeter. So here the point to know is left hilum higher. So left hilum higher. Whereas left dome of diaphragm downer. So this is something normal. So hilum will be slightly up, whereas dome of diaphragm will be slightly down on left side. The center of right hilum is at level of third rib anteriorly. So center of right hilum is at the level of third rib. Ring-like shadows around hilum is end-on bronchus, and solid shadows are blood vessels. So generally at the hilum, if you see any ring-like shadows, don't think it is bronchiectasis. So these ring-like shadows are usually end-on bronchus view, and sometimes you can also notice a few solid areas. So solid areas like this. Again, don't think these are any masses. So these can be blood vessels. So here what you need to know about normal hilum. Left side hilum is higher. At the hilum, if you see any ring-shaped shadows, don't call it as bronchiectasis. It can be end-on bronchus. And if you see any solid shadows, first don't think it is, see here, you can see a solid shadow here. Don't think it is any lymph node, or if it is small, don't think it is any lymph node or any malignancy. Think of any possibility of blood vessels. Then coming to trachea. So the trachea is usually placed just to the right of midline. So slight right is the normal position. So I think this everybody know. So trachea is slightly towards the right. If trachea is pulled towards the side of disease, if trachea is pushed towards the side of disease, what are those diseases? We will discuss later. So again, you should also say what is the position of trachea when you are explaining the density. Then coming to diaphragms, I told you left diaphragm higher as the right diaphragm higher than left diaphragm. So left diaphragm or left dome is downer, whereas left hyla is higher. So here hyla on the left side high, diaphragm will be down when compared to right. Difference should be less than 3 centimeter and outline should be smooth. The highest point of right diaphragm should be in the middle of the right lung field, and the highest point of left diaphragm should be slightly more lateral. So this is something normal. So in the right, the diaphragm highest point should be at the center, whereas at the left, highest point will be slightly lateral. So highest point will be lateral on the left. So this is what you need to know. Highest point on the right diaphragm should be in the middle, whereas highest point of the left diaphragm should be more lateral, And the curvature of the diaphragm, drop a perpendicular line from center to line coming from angles. It is generally 1 to 1.5 centimeters. So if you notice here, so right diaphragm slightly higher than the left, and the contour should be definitely very visible. So for the curvature of the diaphragm, drop a perpendicular line from the center to the line coming from angles. So what are the two angles that you should know? So what is this angle called as? Costophrenic angle. And what is the angle here called as? Here also you will have that angle. It is called as cardio. So here precisely cardiophrenic angle. So what you need to do is you have to join these two angles and you have to draw a perpendicular to curvature of the diaphragm. So this should be usually 1 to 1.5 centimeter. So it should be 1 to 1.5 centimeter. So if it is less than 1 to 1.5 centimeter, it means it is not a curved diaphragm. It can be a flat diaphragm. So draw a line to the curvature of the diaphragm and also a line joining the two angles, cardiophrenic angle and the costophrenic angle. So the distance should be about 1 to 1.5. If it is less, it is a flat diaphragm. So generally they are not going to ask you regarding the curvature of diaphragm. They might ask you regarding elevated hemidiaphragm, and they might ask you normally which diaphragm is downer. Downer diaphragm is left diaphragm slightly down. So this is the angle that we were speaking. This is the curvature that I was speaking about. So this should be 1 to 1.5. This should be 1 to 1.5 centimeters. Then there are some black spots. So they might ask you, what are the black spots or hidden areas on chest X-ray? So we generally tend to miss the lung apices. We generally tend to miss retrocardiac shadows. We generally tend to miss what is there under the diaphragm. After scrutinizing the bones and soft tissue, remember to look the pathology in the hidden areas. So most probably as a pulmonologist, the right upper zones are very important. So if you see some faint infiltrates in the upper, I have seen in many patients faint infiltrates in the upper zone. How come sputum CB not positive? They might have been missed on microscopy, but now we are having CBNAT, it will pick up. So just by seeing that these patients were all referred to me for chronic cough who have been taking inhalers and multiple courses of antibiotics from outside. Just 2 minutes history and 1 minute scanning of the film, we could give them life-changing diagnosis. So look at the lung apices, the retrocardiac areas, and also under the diaphragm. So especially in this retrocardiac area, I once have seen a bulging here which turned out to be a Pott's spine. So this patient was having some back pain and he was having fever, weight loss. He was referred to me for fever and weight loss. When I have scanned his chest x-ray, I could see some paracardiac, retrocardiac area, some bulging was there. So then we have done an MRI spine. So it was suggestive of Pott's spine. So that's why be very careful on hidden areas. This a practicing physician should never miss. Then look at the bones and soft tissues. So scrutinize every rib from anterior to posterior. So from anterior to posterior, the ribs, clavicles and vertebra. Now in few exams what they can give is, they can give a chest x-ray showing an accessory rib. So you'll be looking at the complete chest x-ray and you will be thinking what is the abnormality, what is the abnormality. But there might be an accessory rib also called as cervical rib. So this never ever forget. So this happened to me in my MD final exam. So they have given me some 5 to 6 x-rays. I could answer all the x-rays. Last x-ray, this was examiner's personal x-ray. He have given me the x-ray and he asked me, what if you tell the abnormality, I will pass you without asking any questions. So even though I have mentioned, I have answered all the prior 5 x-rays, but examiner was still not convinced that I was eligible to pass. So then I have seen the x-ray film, I have scanned every part. So I have seen the heart, the diaphragms, the hyla, the lung parenchyma, the mediastinal contour. I thought I could not say it is a normal x-ray because if I say it is normal and if it found to be abnormal, then it will be problematic. So I was thinking, why will examiner give me a normal x-ray? So then I have seen in the apices, I could see a incomplete rib. I told him it was cervical rib. Okay, you are passed, he told me. So like that, few examiners, sometimes everything will be normal. They'll be carrying that cervical rib x-ray. Don't forget, you should also be able to recognize this abnormality. Then let us see some frequently asked chest x-rays. So this is a consolidation. This is a chest x-ray of consolidation. So normally on a chest x-ray, you have to first see, apart from that part, exposure, all those, then you see the trachea and you see the heart shadow. So normally one third will be on the right, 2/3 will be on the left, and trachea there is no significant shift. Heart shadow is also no significant shift. So this is a consolidation. So how did I tell consolidation? The disease defining feature of consolidation is air bronchogram. So I think everybody can notice in this area of white, you can see blackish lines like this, no mediastinal shift. So just a minute. So I think now it is visible. So this is the classical air bronchogram. Then, can anybody tell me what is this? what is the diagnosis. So you should mention like this. So this is a chest X-ray PA view after mentioning all other features. It is showing a right-sided whitish density with air bronchograms, no significant mediastinal shift. This can be probable consolidation. So everybody, can you notice here air bronchograms? So air in the bronchus clearly visualized. So what happens in consolidation? Because of infection, your alveoli will be filled with fluid. So in a normal chest X-ray, your bronchus will be black, alveolus will be black. Why both are black? Because both are filled with air. So in a normal chest X-ray, when two structures are having same density, you cannot differentiate them as two different structures. Now in pneumonia, what happens? Alveoli will fill with secretions. Now against this whitish background, air in the bronchus is clearly seen. This is called as air bronchogram. So why air bronchograms are not seen in normal chest X-ray? Because in normal chest X-ray, bronchus is filled with air, it is black. Alveoli is also filled with air, it is black. So there is no contrast difference. In pneumonia, alveoli are filled with secretions. They appear white. Against this whitish background, air in bronchus is clearly seen. Now with this background, can anybody tell me what is the diagnosis here? Yes, what is the diagnosis here? So if you notice, the trachea is going towards left, and most importantly, the heart shadow. Nothing is on the right. Everything has been shifted towards the left, and there is a left density here. So this is a left pulling lesion. Left pulling lesion. And what is the nature of the density? Even if you look into this density, can you see any blackish lines called as air bronchograms? No, it is completely whitish homogeneous density. So if you find a pulling lesion, whitish homogeneous density, so what should be your automatic answer? It should be collapse of lung. So this is a collapse of lung and left collapse. So this is a left-sided pulling lesion. And see here, even on the CT chest, this is right lung, this is left lung. So this is a part of the lung that has underwent collapse. So if you notice, in this area, can you see any blackish lines called as air bronchograms? No. Now everybody, keep this white in your mind. Keep this white in your mind and compare it with white of consolidation. Now your eyes will automatically recognize air bronchograms. Can you notice here? So these are all the air bronchograms. These are all the air bronchograms. Then with this background, can anybody give me the diagnosis of this chest X-ray? Diagnosis of this chest X-ray. I think it is very simple for you. So I will give you a clue. Disease is on the right side. So what you can see, trachea is pulled towards the right. The diaphragm is also pulled up, and when compared to left, the size of the lung has been decreased on the right. So this is a chest X-ray PA view showing right-sided pull of trachea and mediastinum and right-sided non-homogeneous opacity suggestive of fibrosis. So this is, see, collapse means complete airless lung fill. So it has to be white. So this is fibrosis. So less air. So it will be non-homogeneous opacity, right? Fibrosis. And when you can notice the other side lung has well expanded, you can also mention with left-sided compensatory hyperinflation. So this is a right-sided fibrosis. This is a right-sided fibrosis. Then what is the diagnosis here? You can see trachea is going towards the left. Heart shadow is also left. And on the right, there is obliteration of both CP angles. Costophrenic, you have to explain like this only. Costophrenic, cardiophrenic angles, and it is a homogeneous whitish abnormality. So you know it's pleural effusion, but you have to describe like this: with meniscoid fluid level high up into the axilla. Meniscoid fluid level high up into the axilla. So this is a right pushing lesion. So this is right pleural effusion. Now examiner will ask you the next question. Why it is not right-sided collapse? Because collapse is also white. Then you should explain that collapse is a pulling lesion. The density, if the abnormality was on the right, trachea must have been pulled towards the same side. And moreover, collapse will not have this meniscoid fluid level. Now by chance, you have identified collapse and pleural effusion. The next question that they ask you is, what are the causes of unilateral whiteout lung? So you know all the diseases, but in stress and anxiety, you may not open your mouth. So that's why last time also I have given you a mnemonic, how to remember unilateral whiteout lung. So it is A, B, C, D, E, F. So this is the simplest mnemonic so that I have designed for exam going PGs. A is agenesis of lung. B means a big tumor. It can be a chest wall mass such as Ewing sarcoma, a lung tumor or pleural mass. So C stands for either collapse, whole lung collapse, either consolidation, and D stands for destroyed lung, fibrosis. And whenever your lung is destroyed, what you have to do, you have to remove it. So this is pneumonectomy. And E stands for effusion. F stands for fibrosis and intense pleural thickening called as fibrothorax. So if somebody asks you what are the causes of unilateral opacified lung, at least 5 causes you should say. A, B, C, D, E, F. A for agenesis of lung, B for big tumor, C for collapse, consolidation, D for destroyed lung, pneumonectomy, E for effusion, F for unilateral fibrosis and fibrothorax. So if you remember like this, you will not forget. If you can at least tell 5 causes out of this 11 causes, examiner will be very satisfied. Now what is this diagnosis? You can notice a hypertranslucent area, and this word is very important. Devoid, without bronchovascular markings. See, you might think, sir, day in and day out, I see all these x-rays. Why will examiner ask these x-rays? So last year for my postgraduates, examiner asked only basic things. So he was particular about this word, without bronchovascular markings. So if you just say hypertranslucent area, he said you are a postgraduate, you should tell it in a systematic manner. So he wanted this word, hypertranslucent area without bronchovascular markings, with collapsed or compressed lung margin. Collapsed or compressed lung margin with shift of mediastinum to opposite side or mediastinum to right side. So if you notice, all this is air-filled hypertranslucent area. What is this? Compressed or collapsed lung margin. And what else has happened? Shift of mediastinum to opposite side. So this is a classical case of left pneumothorax. So I hope all the residents, these are basic level x-rays, but still you should describe them in this format only. If you say just it is right side pleural effusion, examiner will not be happy. So it is a right-sided whitish homogeneous density with obliteration of cardiophrenic, costophrenic angles with shift of mediastinum to opposite side and meniscoid fluid level high up into the axilla. Only if you describe like this, your examiners are going to accept your answer. So this is a left-sided pneumothorax. I think no doubt in this. And always, even in any emergency situation, when patient is having acute shortness of breath and chest pain, always look for any possibility of pneumothorax. So you have to see the compressed lung margin. And now after advent of CT chest, it is very easy. This is right lung, this is left lung. So this is air. And you can see compressed lung margin. And few examiners, even after mentioning all this, I'll give you an example. So they'll ask you, it is left-sided pneumothorax. And the question asked for my postgraduate was, there were infiltrates on the right side like this. So anybody will think this is due to tuberculosis. He wanted to call it as secondary spontaneous pneumothorax. So he was particular about without bronchovascular markings. So then he said, okay, he corrected himself and he said left-sided pneumothorax. No, it's not the right answer. So I want the complete answer. So then he was unable to answer. See, you are seeing a disease on the right. And so it is due to trauma? No, it might not be due to trauma. So it is due to a disease. So it is a secondary spontaneous pneumothorax. So split pleura sign J is not for pneumothorax. So it is for empyema. So when I give you the CT chest spotters, I will show you that. So split pleura sign is specifically for empyema. So there will be enhancement of pleura. In between that you could see fluid. So this is a simple pneumothorax. Then what is this finding? Anybody? What is the diagnosis here? So you can see fluid level. So this is hydro. And you could see air. All this blackish area is air. And along with that you can see compressed lung margin. You could see compressed lung margin. So this is a classical case of hydropneumothorax. So you might get a doubt, sir, there is air fluid level is seen. Why can't it be a large lung abscess? Why can't it be large lung abscess? Now somebody tell me why it is not large lung abscess. So this is what examiner asks you. You will say this is hydropneumothorax. Why is it not large lung abscess? So very simple. Lung abscess generally happens within the parenchyma of the lung. So lung abscess happens within parenchyma of the lung. Within parenchyma of lung. So there will be no collapsed lung margin visible. Whereas hydropneumothorax happens within the pleural space. So you can see this compressed or collapsed lung margin. So this is a compressed, or it can also be called as collapsed lung margin. You will see this collapsed lung margin because it is happening in the pleural space. The pressure effect might be significant and it can cause push of mediastinum to opposite side. Then next question they'll ask you, when you have answered a X-ray on pneumothorax, what are the causes of unilateral black lung? So very important. You should know the causes of unilateral white lung. You should also know the cause of unilateral black lung. And to remember it easily, I have again designed a mnemonic called as ACROS. ACROS. So if you have followed my case discussion previously, this everything I have discussed already. So first A stands for air. What are all the air containing abnormalities? It can be a large pneumothorax, or it can be a large bulla or artery. On that side, pulmonary artery is not developed. Normally, why on the lung you see all those whitish lines? Because of branches of pulmonary artery. Then some chest wall problem. So if there is no muscle, or they have removed the muscle, as in mastectomy and Poland syndrome. And if there is rotation also, you can notice translucency. And if there is any obstruction, partial bronchial obstruction, it can function like a ball valve, and there can be localized hypertranslucency. And if there is large embolus and obstruction, even embolus in the pulmonary artery, because on that side the pulmonary artery is blocked, vasculature will not be seen on that side. When vasculature is not seen, white will be less, so it will appear more black when compared to other side. And S stands for any scoliosis, any Swyer-James syndrome, or surrounding lung increased density. Now suppose on one side there is a destroyed lung, this appears very white. On the other side there can be compensatory hyperinflation, so it appears black. So when they ask you unilateral hypertranslucent lung, out of this 11 you should at least say 5. So think of air, which will contain air, pneumothorax, bulla. Think of chest wall causes. So when there is no muscle, or when the muscle is removed, mastectomy, Poland syndrome, any rotation, any obstruction in the pulmonary artery, partial obstruction in the bronchus, any scoliosis, any Swyer-James syndrome, and surrounding lung increased density, as in compensatory hyperinflation. Now tell me, what is this classical chest X-ray finding called as? So we will go through all these spotters now very rapidly. Anybody answer? Normally the horizontal fissure should be straight, but it has bulged down like this. So this is a classical bulging fissure sign. So this is seen in which pneumonia? It is seen in Klebsiella pneumonia. So Klebsiella generally causes dense right upper lobe consolidation. Because of weight of that consolidation, normally horizontal fissure should be straight. When there is excess weight, it can bulge down. So because the fissure has bulged down, this is called as bulging fissure sign. So this is classical of which pneumonia? Klebsiella pneumonia. Then what is this air-filled area called as? It is cavity. Cavity, the classical definition is, it is air-filled area with well-defined wall. It is air-filled area with well-defined wall. Usually more than 1 to 2 mm in dimension, and it is associated with some ongoing pathology such as consolidation or mass. Consolidation or mass. So cavity of lung, you should identify the air-filled area. Around that, well-defined wall, air-filled area. Around that, you should be able to notice this well-defined wall. So I think everybody can notice. And generally, cavity is happening as a result of some ongoing pathology. So there might be a consolidation, or there might be a mass, and that can be responsible for cavity. And whenever you identify it as cavity, examiner will ask you, what are all the lung diseases? What are all the lung diseases where there can be a cavity? So if you see old books, some 1980s and 1970s, so this criteria was there. At least 3/4 wall should be visible. But now, if there is a well-defined wall, so this is only used. If you take any standard textbooks, it is only written as well-defined wall. So in old days, because the X-rays are not that high quality, so they were taking if 3/4 wall is visible. Now with the digital X-rays, you could see the well-defined wall. Okay, so don't think Jay, if full wall is visible, you cannot call it as cavity. So if full wall is visible, it is 100% cavity. So cavity more than 1 to 2 mm, 1 to 2 mm is cavity wall is 1 to 2 mm. So if it is more than 10 mm or 1 centimeter, more than 10 mm, 1 centimeter, it is called as thick walled cavity. It is called as thick wall cavity. Okay. This is thick wall cavity. See, bulla, it is more than 1 centimeter size, no perceptible wall associated with emphysema. So where is bulla happening? It is happening distal to terminal bronchiole. So where you will have all tiny structures such as the respiratory bronchiole, all those. And this is the definition of bulla. It is air-filled area, air-filled area more than 1 centimeter size with no perceptible wall. You cannot identify the wall. You cannot identify the wall, and it is usually associated with emphysema. So generally bullas will be very peripheral like this. So they will be lined by pleura. So bullas are generally coming from periphery like this. So bullas will be like this. So they will not have any specific shape. They will not have any specific wall. So 1 to 2. Sir, can a cavity be formed within 3 to 5 days? See, if it is an aggressive necrotizing pneumonia, cavities can be formed within 1 week. But within 3 to 5 days, so I don't think it can form, but usually necrotizing pneumonia, cavities can form rapid. So this is the bulla. So bulla will be like this. So 1 to 2 mm size is the definition of cavity. Up to 10 mm, you can call it as, you cannot call it as thin wall. More than 10 mm is generally called as thick wall. Because less than 2 mm, we have cyst generally. Cyst again, you cannot call it as thin walled cavity. So that's why all this, what happens is age-old examiners following the old textbooks, so they do this. But now we have a definition called as cyst. Cyst is usually, I'll also write the definition of cyst. Cyst is usually air-filled area. Cyst is usually air-filled area with well-defined wall. Usually less than 2 mm in dimension. Now tell me, if you take this 1 to 2 mm as a cavity, less than 2 mm is called as a cyst. So just for a cavity, don't call it as thin wall cavity. If it is more than 10 mm, it is a thick walled cavity. So usual thickness of cavity varies from 1 to 2 mm. So why I have taken 1? Because in one book they have given as 1. But the recent definition for cyst, they have given it as well-defined wall less than 2 centimeter. And again, cyst is very difficult to identify. Cyst is very difficult to identify on a chest X-ray. You need a CT scan. For cyst identification, you need a CT scan. But cavity will be identified on a chest X-ray. So bulla, there will be no perceptible walls, and to call it as bulla, there should be some emphysema associated. So cavity more than 10 mm, call it as thick wall cavity. Thin wall cavity, there is no specific definition. Now come on, tell me, what are the causes of cavity? What are all the diseases that can cause cavity? So when you don't know the reason behind any pathology in medicine anywhere, so just divide it like this. So any infection, is it inflammatory pathology? Any inflammatory pathology? Any malignant pathology? Any congenital pathology. So even if you don't know DD of anything, always think in these terms. So what are the infections responsible for cavity? What are the inflammatory conditions responsible for cavity? What are the malignant conditions responsible for cavity? Are there any congenital conditions or other conditions? So congenital or other conditions such as vascular or any trauma like that. Now just by going through this, you can easily identify. So tell me, what are the infections that can cause cavity? We all know. What is the first infection? Tuberculosis. Staph can cause cavity. Klebsiella can cause cavity. Fungal infections can cause cavity. Inflammatory conditions, you must be knowing. Wegener's granulomatosis can cause cavity. Rheumatoid arthritis can cause cavity. Malignancy. What are cavitating malignancies? Squamous cell carcinoma is cavitating malignancy. Large cell carcinoma is cavitating malignancy. So just simple. Even if you don't know any differential diagnosis for any condition, so just think like this. So what infections can cause this? What inflammatory conditions can cause this? What neoplastic conditions can cause this? What congenital or other conditions? So this is an exhaustive table. If you want, you can by heart this, but I have made it in a logical manner. Infective causes, inflammatory causes, congenital causes, vascular causes, neoplastic causes. So infections, first should be TB. So this is number 1 in India. So other infections that I told you, Klebsiella, Staph, histoplasmosis, nocardia, all those. Neoplastic, squamous cell carcinoma, few metastases can cause. Even you can add here large cell carcinoma, even though it is very rare. Inflammatory sarcoidosis also, cavities are rare. Wegener's granulomatosis, rheumatoid nodules, and lung sequestration, bronchogenic cysts, and congenital bullous can also appear like cavity. So these are the conditions responsible for cavity. Then what is this? This is an air-filled area. This is also air-filled area, but the wall is not proper. So this everything you cannot identify the wall. So this is a pneumatocyst. So this is air-filled area with improper wall and generally associated. Even the clinical history is very important. Acute pneumonia. And what are the conditions responsible for pneumatocysts? Pneumatocyst most important infection is staph. Apart from that, Klebsiella can cause pneumatocysts, and pneumocystis can also cause pneumatocyst. Here there is air-filled area, but the wall is not proper. So this is a pneumatocyst. So if you see cavity, see the main difference. So now I will erase this. You can identify the air-filled area with well-defined wall. So air-filled area with well-defined wall. So this is cavity, whereas this is pneumatocyst. Air-filled area, no proper wall is pneumatocyst. Air-filled area, no proper wall is pneumatocyst. Sometimes air-filled area will have both air and fluid. So this is a well-defined cavity. In that there is air and there is fluid. Now what is this condition called as lung abscess? So what are the causes of lung abscess? Lung abscess can be divided into primary lung abscess, secondary lung abscess. Lung abscess can be further divided into primary lung abscess and secondary lung abscess. So what is the cause of primary lung abscess? It is due to aspiration. Because it is due to aspiration, most common organisms. See, TB lung abscess is very, very rare. Most common organisms are oral anaerobes. And out of these two, most common is primary lung abscess only. Whereas secondary lung abscess, it is due to some pre-existing lung disease that can complicate as lung abscess. So there might be a staph pneumonia, a Klebsiella pneumonia, Pseudomonas pneumonia. They can later complicate as lung abscess. Along with that, tuberculosis also rarely can present as lung abscess. Acute necrotizing pneumonia, staph is very common cause of necrotizing pneumonia. Okay. See, localized, the definition of lung abscess is localized parenchymal necrosis. Necrotizing pneumonia is nothing but multiple areas of parenchymal necrosis. Necrotizing pneumonia is nothing but multiple areas of parenchymal necrosis. So if there are such processes happening in majority of the lungs, so it is called as a necrotizing pneumonia. And usually the criteria will be all those areas of involvement can be less than 1 centimeter. And again, famous for necrotizing pneumonia, these pneumonias are staph, Klebsiella, Pseudomonas. Staph, Klebsiella, Pseudomonas. So localized area is lung abscess. Multiple areas of parenchymal necrosis is usually lung abscess. Multiple areas is necrotizing pneumonia. Lung abscess generally it will be more than 1 centimeter size. More than 1 to 1.5, because necrotizing pneumonia they have taken as less than 1 centimeter. So this will be more than 1 to 1.5 centimeters. Okay. So what I feel is most probably examiners will not be focused on sizes, because sizes you will definitely waste lot of time remembering. Size is important for solitary pulmonary nodule. Okay, for lung abscess usually 1 to 1.5 size is generally taken as localized lung abscess. Necrotizing pneumonia, same areas, less than 1 centimeter is taken. Then what are the differential diagnosis of air fluid level? So this again they can ask you, differential diagnosis of air fluid level. So this is also an exhaustive list. So we have seen lung abscess and hydropneumothorax, any area of cavity which can get filled with fluid. Bulla, infected bulla, bronchogenic cyst, then hydatid cyst, hiatal hernias, necrotizing pneumonia, loculated pleural effusion, so that too loculated hydropneumothorax. So to call it as air fluid level, so the name should be loculated hydropneumothorax. So then any infected cavity, mediastinal cystic areas, so they can also present with air fluid level. But for ear level, at least you know these conditions: hydropneumothorax, lung abscess, infected bulla, bronchogenic cyst, hydatid cyst, infected cavity. All this can cause air fluid level. All this can cause air fluid level. Then what is this? Here also there is a cavity and there is something white like this. But if you notice, in lung abscess it was straight level, but here it is curved, and you can see air around this as a half moon shaped structure. So this is also a crescent sign, but to avoid confusion with classical air crescent sign, what is this referred to as? So this is called as Monod's sign. This is called as Monad's sign. And usually the history will be pulmonary TB, completed treatment, chest X-ray taken. So what will be your answer? So this is a classical case of aspergilloma. So J has given the answer as open negative syndrome. Open negative syndrome means, so there no need to be an aspergilloma there. So there will be simply a cavity, continuously patient will be sputum negative. Large cavity, continuously sputum negative, it is open negative. So aspergilloma, also called as fungal ball. Again, this is very, very important chest X-ray for the final exam. So if you find a cavity and within that some mass and around that air like a half moon shaped structure. So this should be not called as air crescent sign, it should be called as Monad's sign. This is a Monad's sign and it is suggestive of fungal ball. So same thing even on a CT scan you can identify. So the first prerequisite is cavity, in that a fungus, around that air like a half moon shaped structure. So I think hyperinflated lung fills we have already discussed. So this is a bilateral, top to bottom, side to side, diffuse pulmonary infiltrates. So this can be a disease defining feature of ARDS. So in ARDS you will find bilateral, top to bottom, side to side, diffuse infiltrates. Now examiner will also give you this X-ray and he'll ask you why this is not ARDS. So what is this? So here you can see more of central bat wing shadows, and apparent cardiomegaly. So this is pulmonary edema. So how do you differentiate ARDS and pulmonary edema? So by patient's blood pressure clinically and any orthopnea, and on the chest X-ray, bat wing sign is seen. Central bat wing sign. So here it will be more in the central part. Central bat wing sign, and there can also be cardiomegaly. Examiner will ask you, how do you differentiate ARDS and is it pulmonary edema? Pulmonary edema, more the infiltrates will be perihilar. So you will have more of perihilar involvement with central bat wing sign with cardiomegaly. So I am asking just chest X-ray. So chest X-ray, why this is not ARDS? Because you can see central bat wing sign, more of perihilar involvement with cardiomegaly. So Kerley lines. So there are actually Kerley B lines are usually seen. So whenever there is interstitial thickening, the fluid, there are three stages of pulmonary edema. So initially only there will be upper lobar diversion, then there will be interstitial thickening, then there will be alveolar edema. So what happens is, this is one alveolus and this is another alveolus. So from the blood vessel, suppose this is the blood vessel. So this is the blood vessel. So in between alveoli and blood vessel, there is an area called as interstitium. So this everything is interstitium. So generally fluid first from the capillary, it will go into interstitium. So once it goes into interstitium, so there will be an interstitial thickening. So this interstitial thickening will appear like Kerley B lines. So if you notice here near the vasculature, you can see some transverse line. Here it is not visible actually. So Kerley B lines happen when there is fluid in the interstitium. So it is interstitial septal thickening. So you can call it as more as, if there was a CT scan, I would have explained Kerley B lines very well. So interstitial septa will get thickened. So that will appear as Kerley B lines. So Kerley B lines are features of fluid in the interstitium. So once the fluid from the interstitium goes into the alveoli, now you will have densities like this. So this bat wing density is suggestive of alveolar edema. So you can, when there is alveolar edema, it is a bit difficult to identify Kerley B lines, generally seen at the bases of the lungs. Then what do you see here? You can see some cystic areas. So you can see some cystic areas, and can you notice here this bronchus? This bronchus is abnormally visible. So cystic areas and this abnormally visible bronchus. So what is your diagnosis? So this can be bronchiectasis. Bronchiectasis. And same thing here also you can notice. So this bronchus is abnormally visible. So this bronchus is abnormally visible, and you can see some cystic areas. So again, this is bronchiectasis, and these findings can be seen very well on a CT scan. So what are these findings called as? Tram-track appearance. Tram-track appearance. And whenever this is the bronchus, if it is abnormally dilated like this, and if it is filled with secretions, mucoid impaction. Now you can notice these mucoid areas just like fingers of a glove. So this is also called as finger in glove appearance. Finger in glove appearance. So whereas the signet ring side and other signs of bronchiectasis such as tree in bud, all will be visible on CT scan. So on a CT scan you can notice signet ring sign, and also you can see tree in bud. So when I upload the CT chest spotters, I will show what is this signet ring, what is this tree in bud. On a chest X-ray, you can either identify this tram-track appearance, you can identify few cystic areas, you can identify finger in glove appearance. And if some examiner asks you what are the types of bronchiectasis, so it is classified as cylindrical bronchiectasis. So if you consider this is the normal architecture of the airway in cylindrical bronchiectasis, so it will be just dilatation. Then we have varicose bronchiectasis. So the dilatation will be like a spindle. Then the most severe form, saccular bronchiectasis. So it will be more with saccular like this. So we have three types of bronchiectasis: cylindrical, varicose, and saccular. Then this is a interstitial pattern. Okay. So this can be seen in pneumocystis pneumonia and ILDs. So here you don't have any densities. You can see some lines or few nodules. So you can see some haziness. If there is a chest X-ray and if you can see some irregular lines or irregular dots, irregular lines and irregular dots. So in simple words, irregular lines or dots. So this is an interstitial pattern. Today, as we are not discussing CT scan, we are just seeing a chest X-ray. This you can call it as an interstitial abnormality. And interstitial pneumonias are atypical pneumonias such as pneumocystis pneumonia, mycoplasma pneumonia, and variety of viral pneumonias. Especially COVID is having interstitial pneumonia, and ILDs. Again, ILDs is an extensive topic. Then if there are multiple nodules like this, So they can be called as cannonball metastasis. And this is also an exam chest X-ray. So if there are cannonball metastasis, what are the differential diagnosis? What are all the conditions which can cause cannonball metastasis? So for this also I have designed a mnemonic called as CRESP. So you all know what is that C. C is choriocarcinoma, renal cell carcinoma, endometrial carcinoma, synovial carcinoma, prostate carcinoma. So usually cannonball metastasis originates from genital malignancies. Or you can just add, because there is renal, urogenital. See, this is genital tract, this is genital organ, and this is also related to reproductive system only. So choriocarcinoma, renal cell carcinoma, endometrial carcinoma, synovial sarcoma, and prostate carcinoma. Then they are dense nodules. So now when you have symmetric nodules 1 to 2 mm millet shaped shadowing, so bilateral, generally symmetric, diffuse 1 to 2 mm millet shaped shadowing. This is actually described with respect to tuberculosis, millet shaped shadowing. So you should call it as miliary pattern. So can you give me DDs of miliary pattern? So DD is differential diagnosis of miliary pattern. Again, miliary pattern X-ray is commonly asked in your oral examination. Examiner will expect you the differential diagnosis. And again, if you don't know anything, infection, inflammation, malignancy. So same thing here. Infections, we all know it is miliary TB. So along with miliary TB, at least say histoplasmosis. Inflammatory, especially hypersensitivity pneumonitis, sarcoidosis, silicosis, and common in India, tropical pulmonary eosinophilia. Tropical pulmonary eosinophilia. And tumor, breast, thyroid, renal metastasis, as somebody have mentioned, lymphangitis carcinomatosa. So from breast it is very common. The pattern is lymphangitis carcinomatosis. So these are the various differential diagnosis of miliary pattern. So all those fungal infections, histoplasma, coccidiomycosis, blastomycosis, and also nocardiosis, non-tubercular mycobacterium can also cause miliary pattern. So miliary TB, histoplasmosis, hypersensitivity pneumonitis, sarcoidosis, silicosis, tropical pulmonary eosinophilia, tumors belonging to breast, thyroid, renal mets, lymphangitis, carcinomatosis. All these are various differential diagnosis of miliary pattern. Now I have given two images. Tell me what is this sign called as. So can you notice tuft of air, similar to a sickle, So this is called as left sickle sign. So it is derived from Greek words. Left means air, sickle means sickle. So it literally describes an air crescent which might be seen between the aortic arch. An air crescent which might be seen between the aortic arch and the medial border of collapsed lung. So the left sickle sign is a feature of left upper lobe collapse. So if you notice that left sickle sign, you should be able to say it is a left upper lobe collapse and refers to a frontal chest radiograph due to hyperinflation of superior segment, of the left lower lobe. So it is due to left upper lobe collapse, and there can be hyperinflation of superior segment of left lower lobe. So that can result in that rim of air. So rim of air interposing between the mediastinum and collapsed left upper lobe. So can you say a sign with right upper lobe collapse? So this is Lufsical sign is for left upper lobe collapse. In right upper lobe collapse, there is a classical sign. So this is called as golden S sign. So when you see right upper lobe collapse, you could see a sign called as golden S sign. So this also you should know. Left upper lobe collapse is Lufsical sign. Whereas right upper lobe collapse, you can see a golden S sign. Now what is this? What do you see? Now if you notice in this chest X-ray, there is abnormal mediastinal widening. So abnormal mediastinal widening, especially the widened mediastinum, right paratracheal. There is right paratracheal enlargement. Right paratracheal enlargement. So to assess this, CECT chest was performed. Now can you tell me what was the abnormality in this case? So common in India. So you can see there is a big lymph node here. So there is a big lymph node, and this lymph node is not keeping quiet. It is actually compressing the trachea. So normally trachea will be of this shape, oval. So whereas here if you see at this level, trachea has compressed. So this everything is the enlarged lymph node. It is in the anterior mediastinum. Now, so later when we have done a transbronchial needle aspiration, it came to be TB lymph node. And later when we have treated, it has completely resolved. It was a TB lymph node. So that's why don't go with sarcoid. Sarcoid is very rare, first thing of TB. So this patient was later diagnosed as tubercular lymph node, and she had very good response with ATT. Now when there is an mediastinal widening, what are your differential diagnoses? So what is the definition of mediastinal widening? Mediastinal contour, measuring, then somebody is very much interested in centimeters, numbers. So there they can ask you, so what is mediastinal widening? More than 8 centimeter at the level of aortic arch. So from the aortic arch, so to this plane, you have to draw the line. If it is more than 8 centimeters. So if it is more than 8 centimeters, it is called as mediastinal widening. So what are the various causes of mediastinal widening? So it can be vascular, so very dreadful, aortic dissection, aortic aneurysm, enlarged pulmonary arteries, any masses. So in anterior mediastinum, if they ask you what are the masses in anterior mediastinum, everything starts with the letter T. It is thymoma, it is thyroid, it is germ cell tumor, teratoma, and another T is terrible lymphoma. So this is how we used to remember. Anterior mediastinal masses, everything starts with the letter T. Thymoma, teratoma, thyroid, and terrible lymphoma. And middle mediastinal and posterior mediastinal masses can also cause mediastinal widening. Then lung, especially the upper or middle lobe collapse, can cause transient mediastinal widening. Atelectasis, nodular masses encroaching onto the vasculature can also cause mediastinal widening. Pneumomediastinum pericardial effusion can also cause mediastinal widening. But examiner will be very much particular regarding vascular and the masses. So when there is mediastinal masses, if they ask you differential diagnosis, at least say aortic dissection, aortic aneurysm, enlarged pulmonary artery. Anterior mediastinal masses, middle mediastinal lymph node enlargement, posterior mediastinal any neurogenic cyst, at least vascular and masses component you should be able to answer. Then lymphadenopathy, as I told you, any lymphadenopathy, hilar lymphadenopathy, paratracheal lymphadenopathy will all cause mediastinal whitening. Then if there is a mediastinal whitening, people will be asking you what is hilum overlay sign. Now the simple logic here is, if through the mass you are able to identify all the vasculature, it means mass is not at the hilum. It is either anterior to hilum or posterior to hilum. If the pathology is anterior or posterior to hilum, then the vasculature can be seen through the opacity. If the pathology is in the hilum, vasculature cannot be seen. If the pathology is in the hilum, vasculature cannot be seen. So here if you notice, you can see all the vasculature properly. It means it is not in the hilum. Here when we have done a CT scan, it was anterior mediastinum. So it was anterior to hilum. So hilum overlay in simple words is, if pathology is anterior or posterior to hilum, then vasculature can be seen. If it is at hilum, vasculature cannot be seen through that opacity. So here, because we are able to see the vasculature through the opacity, so vascular branches, we are able to see the opacity through the opacity, it means it must be either anterior or posterior. So when you have done a CT scan, it was found to be anterior. So this is the hilum overlay sign. So simple words, if there is an opacity at the hilum and you are able to see vascularity properly, it means the opacity is not at the hilum. It is either anterior or posterior to hilum. Now suppose by chance you are seeing a mass in the hilum, then we have something called as hilum convergence sign. So this hilum convergence, and see all this were given by the great Felsen when in the early 20th century all this were followed, but after advent of CT scan, now nobody is looking at hilum overlay or convergence sign, but they will be asked in your exam. So this is used to differentiate hilar enlargement due to pulmonary artery dilatation or hilar lymph node enlargement. Now you have come to a conclusion by hilum overlay sign. Now it is at hilum. Now the doubt arises, is it due to enlarged pulmonary artery or any hilar mass? See here, if the hilar enlargement is due to dilated pulmonary trunk, then the branches of the pulmonary artery appear to converge towards the hilum and meet at the pulmonary artery. This is called hilum convergence sign. If vessels do not converge towards the opacity and instead converge more towards the heart, then the opacity is due to hilar or mediastinal mass. Now suppose this is here lung and there is an opacity here. Now you don't know whether it is mass or enlarged pulmonary artery. Now if the vasculature is seeming to go into the periphery of the mass, so it means this is vasculature. It means the vasculature is going into the periphery of the mass, means all this must be branches of the pulmonary artery. So if this is the situation, this is enlarged pulmonary artery. If hilar enlargement is due to dilated pulmonary trunk, then the branches appear to converge towards the hilum or to meet the main pulmonary artery. Now, if at all this is the situation, if there is a mass like this, and if you feel the vasculature are not going into the vessel, they are going into the heart. So this is not a blood vessel, this must be a mass. So this is not a blood vessel, this must be a mass. So if they are converging into the mass, directly into the border of the mass, most probably it is enlarged pulmonary artery. So instead they converge more into the waist of the heart. So into the heart. So they are not going into the opacity, they are going into the waist of the heart. So then the opacity is due to hilar or mediastinal mass. So just know this. If that vascularity is going into the opacity at the periphery of the opacity, it is dilated pulmonary artery. So not a hilar or mediastinal mass. So now if you see here, this was the mass, and if you trace, all the vasculature were going into the opacity. So if they go into the opacity, all the vasculature, if they go into the opacity, so it is suggestive of a dilated pulmonary artery. So if they are directly going, if suppose the vasculature is directly going, if you feel it is going into the heart, so then it is considered as a mass. It is considered as a mass. So hilum overlay will tell you whether the mass is anterior or posterior to hilum. Hilum convergence, if the mass is at the hilum, is it enlarged pulmonary artery or enlarged mediastinal mass? So these are the things that you should know. So hilum overlay is used for mass anterior or abnormality anterior or posterior to hilum, whereas hilum convergence is to differentiate whether the opacity is dilated pulmonary artery or mass or lymph node enlargement. So I'll just write versus. So this is the simple logic of hilum overlay and hilum convergence. Then in few situations you will get a double density sign. So this is called as double density sign. It is also called as double heart border. Is seen on frontal chest radiographs in presence of left atrial enlargement and occurs when the right side of the left atrium extends behind the right cardiac shadow, indenting the adjacent lung and forming its own distant silhouette. So this is due to, so this two density sign, this is actually due to enlarged left atrium. So can be seen in mitral stenosis. So you can also see there is some straightening of heart border, mitral stenosis. This is double density sign. Then what is this sign? What is this sign? So whenever you see an enlargement at the clavicular area and the examiner is asking you to describe this sign. So this is referred to as cervicothoracic sign, because anterior mediastinum, so anterior mediastinum ends at the level of clavicles. Anterior mediastinal masses, if at all present. So what are the examples of anterior mediastinal masses? I have given you 4 T's. Thyroid, teratoma, terrible lymphoma and thymoma. So it will disappear at clavicles or ill-defined as it ascends above the clavicle. On PA chest radiographs, a mass clearly delineated on all borders above the level of clavicles lies posterior to the level of trachea and completely within the lung. When the cephalic border of the mass is obscured or at below the level of clavicles, it is deemed as cervicothoracic lesion involving the anterior mediastinum. So mediastinal masses posterior to trachea are well outlined above the level of clavicles. So I'll give you in very simple language. Now suppose this is your lung, for example. This is your lung, for example, and let this be the clavicles. Let this be the clavicles. Now there is a mass like this. There is a mass like this. Now if it is belonging to anterior mediastinum, anterior mediastinal mass, generally don't extend on a chest X-ray you will not find, because anterior mediastinum is only up to clavicles, above clavicles. So if it is an anterior mediastinal mass, it will be just appearing like this. Now if it is a posterior mediastinal mass, posterior mediastinal can be seen above clavicles. So more than this, in your Viva exam, no need to answer much about cervicothoracic sign. So cervicothoracic sign will help you to know whether it is an anterior mediastinal mass or posterior mediastinal mass. So this is anterior mediastinal mass, do not extend above the clavicle. Even though they extend above the clavicle, it will be ill-defined. So the mass, it can extend above the clavicle generally, but on an X-ray, it will only be well-defined up to clavicle. Beyond that, it will not be well-defined. So for you to understand in simple words, anything extending above the clavicles, clearly, if you are having a well-defined extension above the clavicles, it is more of posterior mediastinal lesions. So for this, I'll give you some X-rays. Now, this is a positive cervicothoracic sign. This is X-ray A. So whereas this is extending above the clavicles and it is clearly visible. Out of this, A and B, which is anterior mediastinal mass, which is posterior mediastinal mass. See here. So this is only seen up to here. It may extend up this also, but it is not clearly visible. But this mass, if you notice, it is clearly visible over the clavicles. So which is anterior mediastinal mass, which is posterior mediastinal mass. So A will be anterior mediastinal mass. B will be posterior mediastinal mass. So this is in simple words regarding cervicothoracic sign. If it is extending above the clavicles, maybe it is posterior. If it is not extending above the clavicles or it is not properly visible above the clavicles, it is anterior mediastinal. So this is referred to as a positive cervicothoracic sign. So more X-rays for you to understand. Okay. So next is called as juxtaphrenic peak sign. Is also known as diaphragmatic tenting, also called as Catan sign. So it refers to peaked or tented appearance of hemidiaphragm due to retraction of the lower end of diaphragm, which can occur because of collapse of left or right upper lobes. So normally your diaphragm should have smooth contour. So whenever there is collapse of right upper lobe, your diaphragm can be pulled up and it will have a peak sign. So this is juxtadiaphragmatic phrenic sign. So you can have a tenting. So tenting of diaphragm. So this is, it refers to peaked or tented appearance of hemidiaphragm due to retraction of lower end of the diaphragm, which can happen due to pull. When there is left upper lobe collapse or right upper lobe collapse, diaphragm will be pulled up. When it is pulled up, its curvature can modify and it can appear like a peak. This is called as juxtaphrenic peak sign. Then what is this? Whenever you see a well-defined density without surrounding atelectasis, pneumonia or lymphadenopathy less than 3 cm diameter. So what is this referred to as? This is called as SPN. What is this? What is SPN? Solitary pulmonary nodule. First, examiner will ask you what is the precise definition of SPN. Second, what are the DDs? So once again, if you don't know anything, any DDs, is it infection? Is it inflammation? Is it a tumor? Is it congenital? Others. So others means it can be vascular, anything like this. So this is an SPN. The definition of SPN is well defined round. It is well defined round or oval parenchymal opacity less than 3 centimeter. So if it is generally more than 3 centimeter, that opacity can be referred to as mass. So more than 3 centimeter is mass. It is surrounded by pulmonary parenchyma or visceral pleura and not associated with lymphadenopathy, atelectasis or pneumonia. So if there is any lymph node enlargement, is there any collapse, is there any consolidation, then you cannot call it as SPN. So this is the precise definition. It is relatively well-defined round or oval parenchymal density less than 3 centimeter in diameter. It is surrounded by pulmonary parenchyma or visceral pleura and is not associated with any lymphadenopathy, atelectasis or pneumonia. So this is the classical definition of SPN. Now coming to the DDs. So once again, infectious, TB granuloma, histoplasma, coccidiomycosis, ascaris, all this, at least no 3. And malignancy, bronchogenic carcinoma, carcinoid, pulmonary lymphoma, sarcoma, and non-infectious means inflammatory. So this is inflammatory. Rheumatoid nodules, Wegener's granulomatosis, sarcoidosis can be responsible. And others, vascular, AV malformation, bronchogenic cysts. Just read what you can remember and what you can represent in your exam. So knowing 100 things, not representing even 2 things is not worthy. Knowing 10 things and representing 5 things is more than enough. So instead of reading all those 100 things, read 10 common things and try to represent at least 5. You will generally get very good result in any exam. So just divide it into any tumor. Again, tumor, malignant, benign. So benign common is hamartoma, adenoma, and you can also see sometimes lipomas. Whereas bronchogenic carcinoma, carcinoid, pulmonary lymphoma. Infectious granulomas, tuberculosis, histoplasmosis, coccidiomycosis. Non-infectious rheumatoid arthritis, Wegener's granulomatosis, sarcoidosis. And miscellaneous AV malformations, bronchogenic cysts will be visible like a solitary pulmonary nodule. Now what is this? So this is a oval shaped, well defined, rounded homogeneous density, very big. So it is a mass. So mass. So whenever there is a big mass, so you can think of mostly tumor. So lung tumor, you can think of tumor in the lung, tumor in the pleura. Okay. So along with that, you should never forget hydatid cyst. So in our country, when you see such a big mass, so apart from routine tumors, lung tumor, pleural tumor, you should think of even a hydatid cyst. So on chest x-rays, uncomplicated hydatid cysts appear as homogeneous oval or round masses 1 to 20 centimeter in diameter with smooth borders with normal adjacent lung tissue. If cyst ruptures into large airway, then you can get a air fluid level. If cyst ruptures, cyst fragments, especially the rigid mouth parts, may be detected by microscopic examination of sputum of pleural fluid. So when it is intact, it will appear like mass. When it ruptures, it can have air fluid level, it can have water lily sign, all those can be visible. So unruptured cyst will be intact like this. So it can also be a solitary pulmonary nodule if its size is less. But if it ruptures, you can see an air crescent sign. Because CT scan will be more helpful. I am showing the CT scan signs. Or it can have this Kumbo sign or onion peel sign. So all this scoliosis So they'll have some irregularities. So it is called as combo sign or onion peel sign. And mass within a cavity sign. So there will be a cavity and you can see a mass there. And because of those ruptured membranes, they appear like petals of a lily. So it is called as water lily sign. It is called as water lily sign. So all these names you should know. So it can air crescent sign, combo sign or onion peel sign, mass within cavity sign, water lily sign. So the ruptured when it is intact, it appears like a mass. So when it ruptures, it can have air fluid level, combo sign, mass within cavity sign, water lily sign. And also other signs such as serpent sign, because of the membranes. So membranes can appear like a serpent. So it is called a serpent sign or whirl sign. And sometimes only an empty structure is noticed. It is called as empty cyst sign. So at least know air fluid level, then water lily sign. If somebody asks you, you can mention about this empty cyst sign, serpent sign, combo sign, onion peel sign, mass within cavity sign. Then coming to the last differential diagnosis, they will ask you regarding elevated hemidiaphragm. So when there is elevated hemidiaphragm, either left diaphragm is at same level or higher to right. You know, left diaphragm is generally lower. So left diaphragm is lower, right diaphragm is higher. If left diaphragm comes to this level, so that is right diaphragm, or higher than right diaphragm, or right diaphragm is higher than fifth anterior rib. So it is called as elevated hemidiaphragm. So these are the various causes. So pulmonary causes, collapse can pull up, lobectomy, pulmonary hypoplasia, and if there is a subpulmonic effusion also, because the effusion is getting accumulated beneath the lung, you can see as if diaphragm has elevated. Subpulmonic effusion is a common cause of elevated hemidiaphragm. And diaphragmatic eventration, phrenic nerve palsy. And abdominal causes such as subphrenic abscess, primary liver malignancy, any diaphragmatic hernia, gaseous distension of stomach or splenic fracture. But for your exam, particularly elevated hemidiaphragm, what are the pulmonary causes, what are the diaphragmatic causes? Pulmonary causes, collapse, atelectasis, lobectomy or pneumonectomy. All these are volume loss, so it can pull up the diaphragm. Pulmonary hypoplasia, on that side lung is not developed, diaphragm can move up. Subpulmonic effusion, so collection of fluid in beneath the lung. Okay, so the fluid will be collected. This is your lung and this is your diaphragm. It will connected in the pleura, which is above the diaphragm only. So only in the diaphragmatic pleura, as if fluid is getting accumulated, you feel as if the diaphragm has come up. So actually it is not due to the diaphragm coming up, it is due to the fluid contour. Then phrenic nerve palsy, diaphragmatic eventration. So these are the causes of elevated hemidiaphragm. So I think we have discussed more than 25 to 30 chest x-rays together. So we have started with the common consolidation, collapse, fibrosis, pneumothorax, hydropneumothorax. So we have taken the hydropneumothorax. Then we have seen cavity. Just we'll see what are the common x-rays that can be asked. So consolidation, collapse, fibrosis, pleural effusion, pneumothorax, hydropneumothorax, cavity, lung abscess. Then we have seen solitary pulmonary nodule. Then we have seen miliary pattern. We have seen cannonball metastasis. Okay. Then important signs: hilum convergence sign, hilum overlay sign, golden S sign. Then we have seen solitary pulmonary nodule, elevated hemidiaphragm, juxtapenic sign. Then we have also seen double density sign. Okay, like this round about 20 to 25 chest x-rays we have seen. Most probably for any regular exam, if you are thorough with these chest x-rays, it will be sufficient. So lexical sign, okay, and we have also seen how to differentiate hyperinflated lung to normal lung. So just go through this x-rays rapidly, and don't forget when you are describing any x-ray, what should be the points, what is the part chest x-ray, PA view, exposure, rotation, adequacy of inspiration. Just practice with your colleagues when you are reading a chest x-ray so that you will not forget in the exam. And whenever you are describing an abnormality, you should describe it properly. If you are thinking it as a pneumothorax hypertranslucent area without bronchovascular markings with collapsed lung margin, if you are thinking in terms of pleural effusion, homogeneous density with obliteration of cardiophrenic, costophrenic angles with concavity high up into the axilla. So I think for any standard exam, these x-rays will be sufficient. So in the next 2 weeks, 1 week we'll try to complete tuberculosis. In another week, I'll try to complete ABG and ventilator graphs. So by this, majority will be done. So meanwhile, I'll add some more CT spotters, and also the virtual OSCE. Once the program is done, all we have discussed till now, it will be uploaded in a single file. So before your exam, you can also go through that virtual OSCE. So thank you, students.